When we tackle neonatal and pediatric pulmonary decision-making, it all comes down to one thing: a strict age-based timeline. On the wards and on your boards, the exact timing of a kid's respiratory distress gives away the diagnosis. So we're going to break down the next best step logic for these scenarios, starting right at birth and moving through infancy into childhood.
Right out of the gate, evaluating neonatal respiratory distress means nailing down the delivery timeline and the risk profile. You have to ask yourself, is the baby preterm or term? Was it a cesarean or a vaginal delivery? Any meconium-stained fluid? We also need to look at maternal factors, things like diabetes, chorioamnionitis, or prolonged rupture of membranes. And finally, did the distress start immediately, a few hours later, or is it evolving over days? Figuring that out dictates the mechanism and ultimately your next best step. Let's put the major newborn respiratory etiologies side by side. We're looking at transient tachypnea of the newborn, respiratory distress syndrome, and persistent pulmonary hypertension. The underlying pathophysiology here, whether that's inadequate fluid clearance, lacking surfactant, or high pulmonary vascular resistance, translates directly into specific clinical timelines and very distinct chest X-ray patterns. Okay, let's compare the mechanisms of those early presentations. Transient tachypnea of the newborn, or TTN, happens because of a delayed clearance of fetal lung fluid. You'll typically see this in term infants delivered via C-section without labor or in late preterm births. On the flip side, neonatal respiratory distress syndrome, or NRDS, is driven by surfactant deficiency. The big risk factors here are prematurity, maternal diabetes, male sex, C-section delivery, and missing out on antenatal steroids. This lack of surfactant leads straight to alveolar collapse, low lung compliance, severe VQ mismatch, and hypoxemia. Naturally, these different mechanisms give us very specific X-ray findings. With TTN, you'll see hyperinflation, prominent perihilar streaking, and clearly visible fluid trapped right there in the interlobar fissures. These babies get tachypnea and mild distress shortly after birth, but they usually resolve in 24 to 72 hours with just supportive care or a little CPAP. NRDS, though, is a different story. That imaging shows low lung volumes because the alveoli are collapsing. Clinically, they present early with grunting, nasal flaring, retractions, and on the film you get that classic diffuse reticulogranular or ground glass appearance with prominent air bronchograms. When it comes to managing surfactant deficiency, prevention is your best tool. You want to administer antenatal corticosteroids whenever preterm delivery is looking likely. Now, if NRDS does develop, you'll initially support the neonate with non-invasive positive airway pressure, like CPAP. This prevents those alveoli from collapsing at the end of expiration while giving them supplemental oxygen. You only want to reserve intubation and exogenous surfactant for significant disease, particularly if there's continued apnea, gasping, or a steadily increasing oxygen requirement. Moving to term or post-term deliveries, fetal distress can trigger meconium aspiration syndrome. When a baby aspirates meconium, it causes physical airway obstruction, inactivates their surfactant, and triggers a severe chemical pneumonitis. Clinically, you'll see a term infant in respiratory distress right at birth, with coarse breath sounds and a barrel chest from air trapping and atelectasis. The X-ray will show patchy infiltrates and hyperinflation. Keep in mind, pneumothorax is a known complication here, so management relies heavily on supportive oxygen and ventilation. A very severe complication of meconium aspiration syndrome or lung hypoplasia conditions like a congenital diaphragmatic hernia is persistent pulmonary hypertension of the newborn. What happens is that elevated fetal pulmonary vascular resistance abnormally persists after birth, creating a right-to-left shunt across the ductus arteriosus. These patients present with severe cyanosis, respiratory distress, and a very prominent S2 heart sound. Treatment means aggressive oxygenation and ventilation, but you're also going to need pulmonary vasodilators like inhaled nitric oxide, or even ECMO in severe cases, just to break that high vascular resistance. If you have a premature infant on prolonged supplemental oxygen or mechanical ventilation, they're at risk for bronchopulmonary dysplasia, or BPD. This is a chronic lung disease of prematurity where pulmonary development basically arrests. You end up with alveolar hypoplasia and impaired vascular development. The main clinical clue? A premature infant needing supplemental oxygen for more than 28 days. They'll often have tachypnea, retractions, poor feeding and growth, and recurrent respiratory infections. Management focuses on optimizing nutrition, minimizing oxygen and ventilator injury, preventing infections, and occasionally using diuretics or bronchodilators. It's absolutely crucial to differentiate a chronic, stable oxygen requirement from an acute decompensation. If any neonate suddenly develops temperature instability, lethargy, poor feeding, apnea, jaundice, grunting, or tachypnea, your mind should immediately jump to neonatal pneumonia or sepsis. This risk shoots way up if there's a maternal history of chorioamnionitis or prolonged rupture of membranes. Your immediate next best step is to draw blood cultures and start empiric broad-spectrum antibiotics, classically ampicillin plus gentamicin.
Shifting to infancy, in children under 2 years old, bronchiolitis is usually driven by RSV. It starts with simple upper respiratory symptoms, but then progresses to wheezing, crackles, a cough, tachypnea, and increased work of breathing. Management here is strictly supportive. You ensure hydration, use nasal suctioning, and provide oxygen only if they're actually hypoxemic. Do not routinely use antibiotics, steroids, or bronchodilators, and skip the chest x-ray and chest physiotherapy too, unless the presentation is unusually severe or atypical.
Pertussis, better known as whooping cough, follows a very distinct timeline. The catarrhal phase lasts about 1 to 2 weeks and looks just like a standard viral upper respiratory infection. But then it morphs into the paroxysmal phase. This lasts 2 to 6 weeks and brings those severe coughing spells, post-tussive emesis, that classic inspiratory whoop, and marked lymphocytosis. Young infants often present dangerously here with apnea and cyanosis. You diagnose this with a PCR or culture, treat empirically with a macrolide antibiotic, and make sure to provide prophylactic macrolides to all close contacts.
When we evaluate chronic pulmonary issues in kids, we have to distinguish cystic fibrosis from primary ciliary dyskinesia. Cystic fibrosis comes with an elevated sweat chloride test, a history of meconium ileus, malabsorption, poor growth, and male infertility. Management is a mix of airway clearance, pancreatic enzymes, nutrition optimization, Dornades alpha, hypertonic saline, antibiotics, and CFTR modulators if they're eligible. Primary ciliary dyskinesia, on the other hand, presents with neonatal respiratory distress and a normal sweat chloride test, but you'll see chronic otitis and sinusitis, bronchiectasis, infertility, low nasal nitric oxide, and in about half the cases, situs inversus.
Finally, let's look at evaluating subacute or chronic pediatric cough, which is any cough lasting beyond 4 weeks. If the history points to upper airway cough syndrome, your next step is an empiric trial of an oral first-generation H1 blocker. If you suspect asthma, you need to get pulmonary function tests. You should only proceed to a chest x-ray if the patient isn't improving after those targeted interventions, or if you suspect parenchymal disease or an infection right from the start.
So, the big takeaway from this explainer is that clinical presentation timing fundamentally dictates your next best step in pulmonary management. Anchoring a pulmonary disease strictly to age and the delivery timeline eliminates diagnostic ambiguity and ensures your clinical logic is solid.